على بركة الله. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Good evening everyone. Welcome again to educational webinar series organized by Iraqi Stroke Network. All our webinars are endorsed by MENA Stroke Organization. This is the 20th educational webinar. صوتي واضح؟
واضح.
نعم. The human cerebrovascular system is nothing short of masterpiece, a complex network of conduct that sustain the brain. The organ that define our very humanity, understanding his system in depth is not just an academic exercise. It is the key to saving life in moments when every second counts. Tonight, we will embark on guided tour, a roadmap that traces the journey of blood from its very origin at the aortic arch through the greater vessels of the neck into the cerebral circulation that nourish the cortex. We hope you will be able to visualize the cerebrovascular tree, not just a set of name and the branch, but a dynamic roadmap that can guide your approach to diagnosis, intervention, and patient care from the arch to the cortex. We are honored to be joined by Dr. Alhamza Al-Bayati, an international expert with rich experience in developing stroke system across the various settings. We look forward to learning from his insight and applying them to improve stroke care in Iraq and the region. Thank you for being with us. My name is Murad. I am a neurologist at the Nasriya Teaching Hospital. And now over the leader of the Q&A section, Dr. Shafaq, your words.
Good evening, everyone. My name is Dr. Shafaq Faris. I am a neuromedicine resident at Al-Basra Teaching Hospital. Tonight, I will lead the question and answer section at the very end of Alhamza Al-Bayati lecture. Please put your question at the chat box, and I will read them aloud to the speaker. If anyone wants to speak, please press the raised hands button. Thank you. Dr. Aus, the word to you.
Thank you, Dr. Shafaq. It was supposed that Dr. Abbas Fadheel, my dearest friend, and he's happy to intervention neurologist at Basra, and is the unique in southern of the Iraq with a large of successful treatment and management for neuro intervention. He will join us in webinar as panelist. Dr. Abbas Fadheel. Okay, tonight it is my honor to introduce Dr. Alhamza Al-Bayati, an associated professor of neurology and neurosurgery at the University of Pittsburgh School of Medicine. He is the director of pediatric neuroendovascular surgery at University of Pittsburgh Medical City Children's Hospital and associated director of neuroendovascular and stroke fellowship at UBMC Stroke Institute, with focus on stroke pathophysiology, thrombolytic therapy, endovascular technique, and outcome after ischemic and hemorrhagic stroke in adult and pediatric population. Dr. Al-Bayati is actively engaged in national and international research endeavor to advise the understanding and treatment of this condition by combining in-depth knowledge, technical proficiency, and genuine compassion for this under his care. He strives to make a positive impact on the life of critical individual affected by cerebrovascular disorder. Today, he will be speaking on topic he is truly passionate about, Cerebrovascular Atlas, enhanced roadmap from arch to cortex, an essential component in improving stroke care in resources limited setting. Dr. Alhamza Al-Bayati, you are welcome on the word for you.
مساء الخير، شكرا جزيلا كل الحضور. ما أعرف كم واحد هنا أونلاين، أتليست بس المقدمة أحكيها بالعربي. أشكركم هواية على الاستضافة، و هاي أول مرة فشي يعني يسعدني وفشي كلش أفتخر به. صار لي أنا برا العراق تقريبا 22 سنة، وهاي أول مرة يعني بيور عراقي like initiative. so كلش فخور اني يعني فشي ذكرى كلش حتصير حلوه علي، وان شاء الله الجايات هوايه مثل ما نقول. أني مثل ما أشكركم هواية الدكاترة الأعزاء على البانل وعلى الحضور على المقدمة الجميلة، وكلش هواية again أفتخر أنه أكون جزء من عندكم. حتى ما أخذ من وقتكم هواية let's just dive into it. أني الباك جراوند مالتي نيورو ميديسن، هنا ما يسموه ميديسن، اتذكر بالكليه نسوي نيورو ميديسن، بس هنا ياخذوا من يعني الاقامه تسويها راسا نيورولوجي باي اتسلف، ونسوي سنه واحده ميديسن جنرال كل شيء، وبعدين نسوي بيور 4 سنين نيورولوجي، سو اتس نيورولوجي باي اتسلف، وبعدين سويت وراها ستروك فellowship نيورولوجي، عاده فاسكولار نيورولوجي اللي هي كلش متداخله between neurology and neurosurgery، لانه كل decision made عاده neurosurgery. It depends on which place you are and all this، بس عاده neurology. هنا سويت اني بيتسبرغ بوقتها، وكانت كلش متداخله، وبعدين رحت بامري سويت interventional was also kind of very heavy neurosurgery because وانا راح احكي لكم هسه ليش هذا دا احكي هاي التفاصيل. وبعدين صار لي تقريبا 7 سنين اخصائي. تصير متداخله، سو هنا يسموها وير هاتس، البس شفقات، او يعني بالحكايه بالعربي كل واحد عنده different يعني رولز بكل شيء. فمرات عندي بس ستروك واللي هي كلش نادرة، بس نيورو ميديسن على قولتكم، وهو اللي يعني what I do for a living is interventional. So ردت من ممنون لك دكتور الشاهني، اعطيت عدة اختيارات، ومن حكينا على الاناتومي ما راح يعني شلون I bore you guys with البيور اناتومي مال البرين وسندروميك whatever لوكتن سيندروم وهالتفاصيل، لانه هاي جزءكم more proper يعني اساتذه لو انتم يعني شغلات ريجولر بالامتحانات وبالاوسكيز لو بالبوردز، عاده هاي شغله كنا ايفن بالكليه كل السندرومز ماخذيها. ردت اعطي شويه فد مداخلة على anatomy purely على blood vessels, the pipes. So every time you say cerebrovascular medicine or cerebrovascular, generally the division, you talk about any blood vessels that goes out of the aorta to the head and neck, okay? This is like the cerebrovascular. There's cardiovascular that goes everything, the coronaries and all their branches, and there's the cerebrovascular, anything in the head and neck area. So I'll take a deep dive into this. Let me actually, so تشوفون مالتي السهم ده يتحرك لو لا؟ الماوس ولا لا؟
نعم واضح.
Okay, perfect. Yeah, مرات هذا التيمز بنقطة حمراء ستختلف. So yeah, I'm gonna let me just minimize this. Okay, so yeah, we'll talk about all the cerebrovascular, the roadmap. The word roadmap is just like مثل الطريق شو يسموها خارطة عمل أو خارطة طريق على كل الاناتومي اللي تبدين من الايورتيك arch and then goes all the way to the head and neck, to the details of it. Okay, so عادة هي هاي اللي kind of decide everything what comes next. I did 4 cases so far this the past 5 hours or 4 hours. 2 of them were like extremely long, or longer than they're supposed to, all because of this guy. Okay, the aortic arch, how far is it? And then all of us, the pediatric population for me is a piece of cake when it comes to this, because very fresh, very clean blood vessels. There's no blood pressure issues. There's no cholesterol. There's no smoking. Everything is by the book, which is a picture like this, okay? As we all grow, as we all have blood pressure, diabetes, cholesterol, smoke, etc., every single pipe that you see, it's supposed to be a pipe, it starts becoming tortuous. And the reason being, as you might know, each of these blood vessels has these like intima, media, adventitia, it's like 3 coating, if you will. These coatings start becoming, it depends on the comorbidity. Is it hypertension? Is it smoking? Start kind of the elasticity of it start getting stretched more and more, and then becoming more twisty and more tortuous. And then to get from point A, let's say from here to point B in the neck, and instead of traveling in a straight distance, it's going to be quite twisty, and then eventually to get to where you want is going to be longer, more damaging, more potential risk, etc. So this is like the broad picture of why should we care of what we're looking at in the CAT scan. A CAT scan, as you might know, this is a picture, is obviously a cartoon picture, but this is what we call an anterior, posterior, or frontal view of the angiogram, and I'll put all these throughout the talk. Okay, so straight pictures like a chest X-ray, AP view, right? You just go straight. The equivalent to this on a CAT scan is what we call it the coronal sequence, and then you have a sagittal sequence on the side, and then the classic one is what we call it the axial, where you have like this kind of cuts, you go up from the feet all the way up. So as we all know, and then again, interrupt me if you have question, and we might do this. Again, it's a very dense talk, so much branches, so I'll do my best to be as fast as possible, but also pause on what it's important for you all. So the aortic arch, obviously, we know this. There are three major pipes that come out of it: the brachiocephalic, or the innominate artery that comes out of the aortic arch, the first guy. Then you have a subclavian. Out of the subclavian, you have the vertebral artery. And then you have a common carotid artery on the right side. The common and the subclavian, they share same origin, called the innominate or the brachiocephalic artery. And then next stop is the left common carotid artery. And the third stop is the left subclavian artery. This is like the first degree branches out of the first, out of the arch. And then like anything in medicine, anything in the human body, there's always variations, and there's always potential differences, right? This is a beautiful picture. This is almost like a pediatric whistle, beautiful straight blood vessels. You don't even need to cross the arch. Most of what we do in the endovascular field coming in the cath, it's coming from the femoral artery. So you're coming this way in the descending aorta. So the heart is here. This is the ascending aorta. This is the arch. This is the descending aorta that goes down. We're typically coming from the arch, which is the aorta here. You have a AAA. Then you have two iliacs, internal, external, one right, one left. Typically, we go through the right internal iliac, then the aorta, then the descending aorta of the arch, and we come here. More and more nowadays, we do. Today, I did one or two out of the four coming from the radial artery. Literally, you have a radial artery here. You feel it. All of us here have a decent kind of pulse in it, and then the patient gonna go straight and then very close to the table, and you're coming this way. Literally coming all the way, coming this spot, okay? This is the left subclavian artery, and then you have the brachial and the radial and then ulnar. You poke the radial coming all the way, elbow, then clavicle area, then the shoulder area somewhere here, and then you're coming here. This is the right vertebral artery, this is the right common, this is the left common, and this is the left vert, and then, sorry, the left subclavian and the left vert. Any angiogram, anything that you are not have a solid understanding of what is you're looking at, meaning you have a blood, you have subarachnoid hemorrhage, you have some sort of a vasculopathy that you want a proper study of the blood vessels of the head and neck. These are the default. At least you have to do a 4-vessel to a 6-vessel angio, and I'll tell you what are the other two. So bilateral verts, 2, bilateral commons, and then eventually they bifurcate into internal, external. So each of these are 4, and 2 verts, 6. Okay, so these are like the minimum. That's why we hammer this. It starts, who cares about the arch, etc. No, we do care a lot, because we can spend 30 minutes or 5 minutes navigating our catheter to where we need to. The more time, the more we say wire time is a problem time. Every time you put a wire, there's blood around it, there's clots that can form and cause harm to the patient. So variants, we talked about like Kulqaida Shawan, right? There's everything, there's a bunch of variants to this. We all, again, I think in basic anatomy, we all heard about the word bovine. Bovine is, again, a fancy word of saying the left common getting plugged to the innominate, okay, or brachiocephalic. So either the left coming here, or is literally there's this kind of stem, and then they bifurcate, and instead of right common, right subclavian, there's also another one, which is the left common. Okay, you have the aberrant right subclavian. Again, aberrant, a fancy word of saying it's not taking its right course. Okay, instead of coming this way, it's coming all the way and then goes there. Why does that matter? Remember, I just told you you're coming there. So with your catheter, you put a wire and catheter here in the right vert. This is the first stop. Second stop, right common carotid. And then you're expecting, if you're not looking at the CT scan, you're expecting your next stop is going to be the left common, and then your fourth stop going to be the left subclavian. If you ended up with an aberrant right subclavian artery, you're coming this way, and you select the vert, which is fine. Then you push, you're trying to go up, you're thinking you're here, you're absolutely not. And then you go, 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 and then you ended up in the descending. It's like, how did I do that? Where is it coming from? And then you go look at the CAT scan. We spend good amount every day in the morning on our rounds before we poke any patients to understand all this. Analyze the pictures, takes you a few minutes, but save you a lot of radiation for a patient, a lot of contrast amount that you give to the patient, wire problems, clotting, etc. So these are, again, everything matters here. That's why we're hammering all this. And then let's keep going. So let's get the verts out of the way, and then start focusing up north into the common carotids and the external carotids, and then the deeper branches in the MCA and ACA. So let's get the verts out of the way. Again, we talked about these brachiocephalic. Let me see. Okay, so another one that we kind of you would ask, what else comes out of the subclavians? And there's like 9 branches. Do we care? Yes. Do we really have to in our day-to-day living? Not really. Why? Because they come handy. In my practice, we have to name every single vessel, not to torture people, but they are equivalent for certain reasons. Definitely the subclavians and bilaterally. A lot of times, I wouldn't say as much as the cerebrovascular, there's a spinal vascular problems that's also under our practice that we care about. So the cervical spine in the back, anything in the back comes, as you can think about, here you go, these are the cervical spine. You can think about this is always, there's a vertebral artery sitting in that neighborhood. So that's always something to blame if something is happening, but everything else is mostly from these guys. They are way low. You would think they are not problematic, but there's the thyrocervical trunk, there's the costocervical trunk, there's the mammary. All these technically are some branches that we should know about, at least. And then every time you think about cervical spine, beside naming other branches that goes in that neighborhood, you think external carotid artery, you think the vertebral artery. Anatomy is very painful. I hated it when like in college, and then even learning more details about things because we all know it's you read it, you crumb it, and then you go test, and then tomorrow you forget about it. But all of us eventually get kind of specialized in certain things. And then the beauty of the anatomy comes back. Everything makes perfect sense. As long as you know what you're dealing with and what's the neighborhood, you will just be able to name things right there. So again, bilateral subclavians, the verts comes out of it, bunch of other trunks, costocervical, thyrocervical, bilaterally. Keep going. So think about it, we're just like dissecting level at level, okay? And then we talked about the arch, we talked about subclavians, the branches of the subclavians. Let's spend a minute on the vertebral arteries. You think vertebral arteries, always think about basilar artery, but there's a lot before the basilar artery. Why matters? Because again, you have a problem in the basilar or the VB junction, vertebro-basilar junction, doesn't necessarily have to be started there. It's actually very unlikely started there. Why? Because that spot is very, very like buried inside the skull. So you have a dissection, you have a buildup plaque, etc. The odds of it to be right there started is I wouldn't say impossible, I wouldn't say rare, but I would say unlikely. Why is that? Because you have all this artery that would eventually end up in the bilateral vertebral arteries in the brain. So think about this here, the left vertebral artery, there's a right vertebral artery. About 20 to 30% of the time you have about what we say one dominant, one less dominant, or non-dominant branch of the two. Typically, the left is the dominant vertebral artery. The right is the less dominant vertebral artery. Put this in mind. Co-dominant, they exist about 50% of the time. And then some people don't even have one, they're just born with one. The other one's called atretic. It's another level down from the non-dominant. Non-dominant is just smaller. You think one bigger than the other, you simple, just say this is smaller than this, less or non-dominant and dominant. They're equal, co-dominant, and there's a very trickle tiny thing, it's atretic essentially. Everything we love to kind of split things, so easier to memorize, easier to kind of, when you talk the language, people understand what you're explaining. You say, oh, left vertebral artery dissection. Well, I need more. Where is it? And you can't just say, oh, this when it turns, whatever. So it's simple. Everything we stage or we grade or we split. So there's this starts from the subclavian, the origin or the ostium, they call it. This is V0. Some books qualify it as a V0, but more so than not, they would just call it V1, which is from the origin of it all the way to C6, okay? And then from C6 to C2, this is V2. And then when it exits the tunnel or the transverse foramen, this starts to be V3. And then kind of loops, and I'll show you a better picture eventually, kind of loops around and become, start piercing the dura, so become V4, and then eventually they meet bilaterally to create the basilar. Why all these matters? Because a lot of us, probably all of you guys on the clinical daily, you might run into again accidents, etc., and then people come with a dissection of the vertebral artery. The odds of the dissection happen in two spots. Very simple. The spots that are not protected. What I mean by protected is they're not in kind of buried somewhere. So out of this picture, you can clearly tell that's from here to here. The vertebral artery just inside the bone, okay? Unless you trash completely your cervical spine, all these C2 to C6, you're technically good for the V2 segment. The V1 or the V0 down to C6, this is unprotected as well, but the good news, you see the clavicle, you see kind of chest and all the muscles, unless you have a massive car accident, massive seizure, in the books describe that, you cannot literally dissect that segment. The most common one, which we all probably seen, the chiropractor, the major accidents to the neck, is this. This is unprotected, leaves that bony canal, go literally hanging outside and then pierce the dura. This V3 segment is the more also unprotected. So V3 and V1 are the most unprotected. V3 is the most vulnerable because where it's located to have a dissection. All right, let's keep going. ECA branches, again, for the sake of time, and I know it's a long talk, so and I almost kind of all the time I leave few slides behind. So for the sake of the purpose and the audience kind of clinical application every day, I'll just highlight what's important and why do we even care? Why do we care about ECA branches, right? It's a facial, it's more of kind of maxillofacial branches and goes to the traumas or like dentist or OMFS, which is oral maxillary facial surgery team. They kind of deal with issues in the face, and then these are becoming more applicable. The most important reason why these are important to the brain, to the neurovasculature, they are literally backup system to the brain, to the ICA, to the MCA. They get activated when you have a problem. Not all of us do have a very solid activation system, and I'll talk about this in a second. They exist. They should talk to each other, the ICA and the ECA, in certain collaterals. We call the dangerous anastomosis. Why they are dangerous? Because you think in the face and you're going after like a tumor, a juvenile nasopharyngioma, typically like near the nose. The surgeon will call us. it's a nasopharyngeal kind of surgery. They get access this way, and then before they open the mass with the tumor, they want some blood control, right? So we go catheterize. This is the common carotid. This is the ICA. This is the ECA. We go all the way in the maxillary facial branches, all the way to the tumor, and then slowly inject material to shut down the tumor completely, dry it up, if you will, just shut down the blood. So when they start taking it or shave it out, it's less bloody, less dangerous for the patient. So this is this. Everything else, so these are quickly here. Superior thyroid artery doesn't really have a lot of application. The occipital artery is extremely important. A lot of the dural arteriovenous fistulas. Dural arteriovenous fistulas happen usually from extracranial to the intracranial connection. You can have what we call dural fistulas that people can have bleeding, can have tinnitus near the ear. As you can see here, near the ear, you can have a dural fistula that kind of give you the whooshing sound or the tinnitus. You can have veins that kind of start getting engorged and then goes to the head and start causing brain bleeds. So these like very, very important. And the more important part about it, it connects one of the quote unquote dangerous anastomosis. Remember I said dangerous anastomosis, this guy. Why? Because it connects with the vertebral artery. Think about it. It's here, it kind of bifurcates. One usually goes to the brain, goes to the ICA, and then ECA, and then we are here somewhere kind of in the mandible, and then the first guy goes behind the ear. What else is in the back? There is a vertebral artery. So they connect. There is an anastomosis that exists. It is dangerous. Why? Because you think you're in the extracranial branches and no way you can do something not right for the patient. However, you can reflux, goes back to the vertebral artery and give a patient basilar stroke, pontine stroke, etc. So that's very dangerous, obviously. And then again, facial, lingual branches, auricular branches, keep going, STA, superficial temporal artery. Again, I'm just kind of giving you a clinical application of each of these. That's why we're talking about them. What is the clinical application of STA? When you have bypass, my good friend, I don't know, maybe all of you on the talk here know or know of him, Samer Al-Amari, Samer Hoz. He was my classmate. He's here now. He's an excellent neurosurgeon. Yeah, he used to do STA MCA bypass. This is the burrow where he burrowed the STA to MCA. So it's very close in there. So it's good to know what you have to borrow from. If there's no STA, there's no bypass, right? So this is like essentially one of the branches, very important. And then you have the IMAX, and then the middle meningeal artery. The middle meningeal artery nowadays, I don't know if you're all familiar with this problem, and it's been almost 5 years here in the US and even in Europe. It's picking up very. Out of the 4 cases I've done today, 3 of them were MMA embolization, middle meningeal artery embolization. We come in the ACA, go here, another dangerous, quote unquote, I told you many dangerous now so far, another dangerous anastomosis. There's a connection between the middle meningeal artery and the eye. So we're going there into the deep branches of the middle meningeal artery, somewhere in here. You're trying to shut down these tiny blood vessels that exist because they are what cause subdural hemorrhages. So as we all know here, there's subarachnoid hemorrhage, there's intraparenchymal hemorrhage, there's subdural, there's epidural. Remember all these kind of crescent and the lens shape and all this. What is every time you say subdural, what is the treatment? Surgical Burhole, right? We learned this forever ago and it's keep application. Now, has been more and more not the case. Sometimes actually they happen simultaneously. If they're very sick, they will take it emergently for Burholes, but they come down and we go same way. Go on the groin or the arm, go travel in the common, ICA, ECA, we go all the way there. Travel here to the IMAX and then go all the way internal maxillary artery, middle meningeal artery, you see this, and then go all the way and inject this kind of glue material to shut them down. So I'm kind of giving you, as the anatomy keep going, I'm giving you kind of a clinical application of what is important. All right, so we'll keep going. We talked about most of these. This is a cartoon, again, picture of mostly lateral. Lateral, again, think about it, sagittal on the non-invasive MRA is called sagittal on the side. Lateral is on the angiogram. Where middle meningeal artery, this is the one I was telling you about. This is a spinosum. We all know foramen spinosum and the skull base. We should know about this. It's a common in the board. Usually they ask us about this. What foramen that comes from the middle meningeal artery, right? Or like this goes related to the epidural or subdural. STA, we talked about it here. And these are IMAX. So the IMAX intermaxillary artery here. All these palatine, phenopalatine, pterygopalatine, all these kind of palatine, and there it depends. Sphenoid sinus, or sphenopalatine, or pharyngeal. They're kind of long names, very hard to memorize. But essentially, think about anything close to the nose. The application is two things: either nosebleed, epistaxis. We get called a lot about it. For uncontrolled people, ENT go in, put pack, but it's still bleeding. Patients go there, so we go blindly, literally. Sometimes we don't even see where it's leaking from. Very safe area, just go there and inject or put coils to plug this area. Or tumors, again, I told you about you go in there and shoot in the tumor itself. Middle meningeal and the subdural, occipital, and the posterior auricular and ascending pharyngeal. These are branches that goes mostly for dural fistulas. Okay, let's keep going because it might definitely not going to finish on time, but I'll pause and then we can finish if that's the case later. So okay, we talked about this. This is an angiogram. So you're seeing here kind of a basic cartoon picture. We talk about application, and then angiogram is what you see here. So this is a picture, lateral angiogram. How do you describe this? This is an angiographic study. You have to say, so you say MRI, okay? MRI because you see MRI, CT scan or X-ray, you see CT because you see kind of thick bone, white stuff. So that's number one. What kind of study? What kind of sequence or what kind of the projection, if you will. So this is a lateral angiogram. And where is it? What are the angiogramming, right? I know it's a common carotid artery. Why? Because you can see the ICA and the ECA. If you ask me, is it right side or left side? No idea. Because it's only one side. Think about it. You can shoot the right side, it looks like this, or you can shoot the left side, it looks like this, unless you have the AP view to tell which side are we at, okay? So that's the ICA, and then we start, and then we named all these branches nicely and their clinical application. This is a little bit quite advanced, but I was telling you about the MMA, middle meningeal artery. This is literally a magnified view of this neighborhood here, right here, okay? So we're right here. MMA, middle meningeal artery, and all these branches, it's too confusing. Foramen ovale, foramen spinosum, we know all these, we should know them, because that's the middle meningeal artery piercing the bone, become intracranial, and that's where you access and you give all these branches. But you see why I say dangerous. You see how close these guys, all of them, to all these tiny branches from the ICA. So you might be thinking, okay, I'm in the middle meningeal artery, I'm good, I'm just gonna shoot stuff. Shoot stuff, literally, you put like this onyx material, like lava, just slowly transmit and goes and shut down the blood vessel. But then the next thing you think about, you're in the ECA, it's a middle meningeal artery, and look at all these connections. Inferolateral trunk is a very established connection that you should, petrosal branch here, PBR, petrosal branch of the middle meningeal artery, is definitely connected to the ILT, to the ICA. So God forbid, you're in the MMA doing a subdural, and then you're done. Patient is not moving contralateral side or vision loss because you see how close this area to the vision ophthalmic artery, all these connections. So these are very, very, that's why they're dangerous. So it's important to think about and know about them. Okay, now we keep more to the kind of area that's important and on daily living. So carotid bifurcation, typically C2, C4, very important landmark to understand where that is. Angle of the mandible is typically the bifurcation. So I named, you remember, we talked about V1, 2, 3, 4, or V0, 1, 2, 3, 4. Here, the same concept. The C, the carotid, there's a bunch of folks, Boutier and Fisher, usually the more common acceptable lingo. You can see there's C1, 2, 3, 4, 5, or C1, 2, 3, and then a bunch of stuff, and then C1 to C7. Out of all the three, this is the Boutier classification is the more acceptable, and people are, if you say Boutier, C1 or C3, people understand what you're talking about. So let's dive into it. So cervical ICA, bifurcation all the way to the cervical. This is C1, okay? And I think, let me see here, maybe I'm kind of going one by one eventually. Yeah, well, let me just talk and then we can go faster later if they're repetitive on slides. Again, we split things, we stage them to make it easy to understand. Number one, make easy to understand the clinical applicability. Who cares? It's a carotid artery. You can have a problem anywhere and you can have the same stroke in the MCA, right? It matters. Why? Because how do you fix? You want to tell the patients you just had a stroke. Doc, why did I have a stroke? Well, let's take a step back. Do you have a plaque here? Do you have an ICA dissection here? Do you have ICAD, intracranial atherosclerotic disease? Typically, any I intracranial starts from here up, okay? So cervical ICA is the last piece that's extracranial for the ICA. Is the only, so it's a board question. What is the only extracranial segment of the ICA? Very simple, cervical. Remember that, very easy, okay? What is the first intradural area? So there's intracranial and there's intradural. Why is it so big deal? Because intracranial, it's in the skull, okay? Cranium, skull. So the first becoming intracranial, think about it, the ICA, the bifurcation right here, goes and then pierce right here, the cheekbone. This is the petrous bone. This is your landmark here, okay? Anything beyond that, this is the turn here, it goes right there. From this point forward, it's intracranial, inside the cranium. Okay, that's one. And then you have a dural space and dural ring, which exists somewhere here between C5 and C6. Another board question, what is the first or the, whatever the, yeah, it's usually saying, what's the first branch out of the, or the first segment of the ICA intradurally? It's the ophthalmic, okay? Why does that matter? Because if you have aneurysm here and blood, by default, you will have subarachnoid hemorrhage. Subarachnoid is under the dura, is inside the dura. So if you have any problem in the vessels inside the dura, equal subarachnoid hemorrhage. A whole bigger deal than any other hemorrhage. There's the mortality 30%. They will go EVD. It's a huge deal, okay? If you have it extradurally, any aneurysm, yeah, there's what is the another board question, and kind of I try to kind of emphasize why am I even talking about all these things? Because we get asked about cavernous sinus, okay? And these are like the foramens that we get kind of people keep. What foramen spinosum? What's foramen ovale? What goes through this? What, it's like, if you think about it in this kind of, you put pictures on top of these names, it makes perfect sense, right? So, and the same thing, cavernous sinus, what goes in it? We all know there's cranial nerves, there's blood vessel. What is the blood vessel? Is the ICA. Where is it? Is the most medial part of the cavernous sinus. Which one is it? Is this guy. Very simple. And then what runs next to it is cranial nerve 6, the abducent. What does the abducent give you? Again, I'm not talking applied anatomy here or clinical anatomy with the cranial nerves and strokes details and all this, but I'm just purely vascular problems. Here is where you have aneurysm start pinching. So the very first problem from an enlarging, not every single aneurysm in the cavernous sinus give you ophthalmoplegia or cavernous sinus syndrome, but the very first things you lose your abducens. Why? Because they're next to each other, and then you start punching on it, bulging, and start squishing it. And the nerve is not like, you don't need so much problem around it to cause you to have a cranial neuropathy. All what it gives you is just like a little bit irritation of the cranial nerve sheaths, and boom, you lose your cranial nerve. So typically patients present ipsilateral, kind of failing to AD duct, AD duct rather. So it's just midline. The third up, down, left, inwards, this is functional. The fourth, the superior oblique, functional. The lateral rectus or the 6 is out. So patients cannot look this way if it's ipsilateral. Okay, and then, so yeah, this cavernous, this is C6, which is the ophthalmic, and then the terminus or the communicating, this is a huge deal as well, because a lot of aneurysms lives in that neighborhood. And then the terminus here, which is MCA and ACA. So we talked about C1, C2, petrous, and lacerum. These are like fairly benign. Why? Because again, it's all about where do you live, right? We talked about the V2. It's buried in the bone. The odds of being in the news is very unlikely. Why? Because the bone protecting it. yes, you can have skull base fracture, you can have transverse foramen fracture in the spine, the cervical spine. Yeah, but you're not going to be only that. You're going to be way sicker patient than just dealing. They will tell you, oh, the patient also have a dissection in the petrous. So the odds of you having only a petrous dissection without anything is extremely almost zero. I can probably say this very confidently because this area is buried in the bone itself. So typically either starts here and extended or like some cavernous, anything in the skull is unlikely to have a dissection. Okay, let's keep forward. We talked about all this. Yeah, we remember I said about the ophthalmic and the dural ring here, somewhere in this neighborhood. So this is a magnified spot. The clinoid on the CTA, you see a clinoid bone. That's an important, again, landmark because what lives here, the dural ring, just distal to it. The dural ring has a proximal and a distal. Why do we care about dural ring? Because that's the landmark, as we talked about, becoming ophthalmic, becoming intradural space, which means subarachnoid hemorrhage if you have a problem. And then we talked about the communicating. Okay. So we'll go faster, I know, because again, we can talk all day about each one of these branches. We talked about cervical, there's no branches, very easy. There's two branches of the petrous. Again, their application is mostly for dural fistula, so it's very, very kind of nuanced problems. These three, ventral trunk capsular meningioepiphyseal, they usually goes kind of either back to the vertebral circulation or the front to the ophthalmic. And then ophthalmic segments, we talked about it, give you the ophthalmic artery, very, very important. We talked about amaurosis fugax. You might see it in the ER. People, a curtain, they drop there is not like cranial neuropathy, is like classic painless vision loss as a curtain. You can't go wrong with that. Very, very important syndrome. And then again, you can have a plaque, and this is the problem because it's the first branch into the dural space. Superior hypophyseal goes to the pituitary, posterior communicating artery, crucial artery. Why? Because it connects the anterior and the posterior. So people with Moya disease, when they are blocking everything, the back will start filling the front. And this is the highway that's potentially still valid and start flowing. And lastly, anterior choroidal artery, also in the communicating. This is one of the most unforgiving blood vessels in the brain compared to its size. It's very tiny. Right here, one of these guys, very tiny. I bet I have some pictures coming here. This is one of these guys. Okay, this is probably, yeah, this is one of them. Very tiny. You spend there for a minute, you have a clot, it's over. Why is it over? Because when it goes, you might know this already, it fills the posterior limb of the anterior capsule. What does that cause you? Significant weakness, complete paraplegia, contralateral. You can have facial, there's syndromes to it. You might already very aware about all this. So like the anterior choroidal artery, anything capsular, quote unquote, strokes or deep strokes. This is one of the most, like this one. And then there's another one we'll talk about, which is called the Humener artery. You might the recurrent artery of Humener comes out of the ACA, the A1. It also fills the head of the caudate and the anterior limb of the posterior of the internal capsule. Facial weakness. You have this. Remember this kind of draw with the leg and the arm and the hand. Remember, like the lateral or the midline. Usually, that's a problem from the ACA. Okay. So we talked about these. We talked about all the branches. Again, I start with this: branches, tables. You've seen the theme. This is picture of the angiogram. Again, very simple. If you memorize this picture, you know literally what that means. Cervical, petrous, all this tortuosity. Ophthalmic is the one goes anteriorly, and the A core. And then eventually the terminus ICA. This is lateral. Remember, we talked about lateral being sagittal view. The coronal view on the MRA or the CTA is the one that's front. And then that's typically where you have the AP view. Okay, you can see here, we talked about the AP view. This is the eye on the right. This is the eye on the left, the nose. And this is bifurcated into one goes midline, anterior cerebral artery, one goes to the side. All right, let's keep going. So this is a CAT scan picture of everything we just talked about. All right, this is the bone, the clinoid, the petrous here, and then the cavernous segment, the clinoid a little bit higher, the cervical, obviously we know. Why do we care most about this? You see these plaques, almost anyone in your neighborhood or my neighborhood here above the age of 50 have some sort of a plaque, okay, from our food, from smoking, from blood pressure, etc. So this is a common situation where you break something off, goes somewhere, ophthalmic potentially, and everything else we talked about. Even that thyroidal is a very small branch, but you can have an embolic event. Remember, embolic doesn't mean always central embolic from the heart or somewhere else. It could be atheroembolic or atheromatosis disease or atheroembolic. Again, you chip something. Emboli is like a free-floating thing, whether it's a clot, whether it's air, or it's fat. We all know this, right? Atheroma is also could be an embolic. Where is it coming from? Either we cause it. I go there, and if I didn't study the CTA of the chest very carefully or the neck, and I keep flicking around with my wire, thinking I'm in the left cavernous and in the right, the communicating, keep in and out, I might flick something out of this area, and then end up in the brain, and patient have a stroke from a catheter angiogram, which is really bad. Bad feeling is not supposed to happen. So that's why we study every picture before committing the patient to catheter angiogram, because there's always a risk. Okay. So, okay, we talked about all this. Not going to waste more time on this. Yeah, there are variants, everything we talked about. They might connect from the ACA to the ICA in the cervical. The ascending pharyngeal might be reconstituted to the true ICA. That's a very common phenomena. We talked about the petrous bone pulsatile tinnitus, again, because it's near and there. So this is something that could be problematic when it's aberrant ICA. Retropharyngeal. So let me quickly go back. So I want to make sense of what I say. So remember this. So this is dorsal laterally. So this is again anterior, posterior, right? And then here is like this way, okay? Medial, lateral, and then dorsal and the ventral. This is like a more of kind of, you can't describe it because it's supposed to be kind of structural, but typically dorsal lateral, so it's lateral area and kind of dorsal going to the back. This is the typical presentation of the ICA, okay? Common carotid artery, ECA, ICA. This is the most common. Can you have it flipped? Yes. What is that called? Retropharyngeal. Retro is behind the pharynx. Okay, so instead of having this here ICA, this is going to be this way, which is the ICA goes kind of midline. So you can flip this way, both sides. How does it look? It looks like this. Okay, ICA, you see, this is going lateral and this is going medial. The ICA is going here. Okay, the ICA going here. Same plaque, same everything, except they're flipped. Why does that matter? They're almost, they call it kissing carotids. Your carotid arteries almost kissing each other in midline, okay? Why does that important? You have to tell the patients or the anesthesia when they're intubating, they should do their also homework and looking at these nuanced details, that this is retropharyngeal, meaning if they're coming in there and you scratch a branch when you're intubating, okay, it could be an ECA, whatever, lingual, facial, kind of who cares, okay? This is a very tiny branch. There's a lot of vasculature. If you poke the ICA, it's a disaster, okay? His patient can bleed to death because it's just, there's no way out, okay? So it's very important. And also kind of goes in the back and cause issues. Carotid webs, I have a talk 2 hours I can spend on carotid webs, so but this is like also a variant that we could talk about. Okay, so keep going. We talked about the cervical ICA, again, petrous. We named most of these branches. Not gonna bore you. This is very kind of nuanced, more of a neurosurgical kind of nuanced stuff. We talked about all the foramen, most of them that they're applicable, ovale, lacerum. So we'll keep going. Lacerum is a very short segment, almost like hard to pin down. Why? Because there isn't much of a bony landmarks. Okay, there's petrous and then the cavernous and anything in between. There's the lacerum kind of ligament. That is the area where the lacerum segment exists. Okay, so that's what it is. literally petroleum wall ligaments or lacerum ligament is the one that we talk about here. Okay, cavernous, again, we talked about what's applicable to it. There are branches that kind of cavern. There's two genus, okay, posterior genu, C4, so C1 cervical, petrous 2, lacerum 3, very short, C4, which is that siphon. Always remember that, okay? Posterior, going back, and then anterior, and then this is the ophthalmic, so that's why it's anterior. So it goes back and then goes front and then loops and then becomes eventually the intradural space. We talked about the cavernous. There are a bunch of branches near the cavernous sinus. We talked about the inferior lateral trunks and their anastomosis. So we can a little bit go faster. I know we're running out of time. So I'll pause after probably, so just to give you an idea. So there's this, and then there's MCA, ACA, and then back. Okay, so if you guys want to cruise through it for another 5-10 minutes, I can just keep going. Foramen, we talked about this again, the ILT. Remember, we talk ILT and MHT, the foraminal valley. So we're kind of zooming into these very spots, and then told you about the dangerous anastomosis and how they are connected, and can you run into trouble from embolizing or having issues. Again, it's not only dangerous, but they could be the only branches that's filling the entire brain on this side. If you have a cervical ICA, okay, that's abruptly got out for whatever reason, you have a dissection and killed it right on the spot. These branches, the anastomosis, the dangerous, we call them dangerous because we want to make sure that we know they exist. We always say there's no dangerous anastomosis, there's dangerous people who don't know about them and cause you to have a problem. So it's all about like knowing what they are, but they are anastomosis, meaning they existed for a reason, meaning if you shut it down, that your ICA, they should activate, and maybe you're going to have a stroke or a TIA, but they're going to keep the blood flowing to the brain on that side if you don't have a PCOM or if you don't have an anterior communicating artery. Okay? All right, so yeah, we talked about this. We also talked about most of these, so we'll just keep going here. A lot of, as you can tell, a lot of pictures here, just hammering the same concept and the same branches, okay? Okay, not talking to you serious. So keep going. So yeah, MHT, another branch. So we talked about ILT, inferior trunk, and meningiohypophyseal trunk. They both exist from the area of the cavernous sinus. Again, they are typically feeding, either they're, again, dangerous, we say, because they are there, but tiny, or they become bigger if there's a fistula. Fistula, again, you have the artery going to the vein prematurely, and then you start having these feeders that going there. Okay, so you might be also aware of this. There are certain anastomoses. They're still qualified as anastomoses because, and again, fancy word of anastomosis means they're plugged between two arteries that not typical, or typical, but they're not very common, okay? You can have what we call it PTA, persistent trigeminal artery. There are 4 branches or 4 spots that basically can have connection between the front and the back. The front is the ICA, the back is the basilar or vertebral junction, okay? Here they are. PCOM, that's all we know about. It's there, we respect it, it's always there. Trigeminal artery, it should disintegrate. That's why they call it persistent, meaning it didn't disintegrate when we were born. Trigeminal artery, PTA. That's a huge anastomosis. Why? Because again, you're here and then all of a sudden you connect to the ICA. There's a lot of drama between the anterior and posterior, so that's not good. If that lands right here, if it lands kind of more proximal basilar, it's called otic artery or a hypoglossal artery. Again, I don't know what level and what boards you guys taking, but these are board questions. Sometimes they get asked, like, what are the non-disintegrated branches or they are persistent? These are the common 4 branches that stays alive. Okay. Clinoidal, C5, it's around the clinoid we talked about. And then why is it important? We talked about right away, it's the ring. That ring is extremely important, very expensive. You need to understand, are you on this side of the bridge or are we here? Why matters? Because if you have an aneurysm here, by default, I shouldn't be very worried about it. By default, if it's here, I should be very worried about it. So it's like very like yay or nay kind of thing. So it's very important to understand where you're located, and then you can offer the right treatment to the patient. Clinoid and sphenoid sinus, these are more of a bony landmark. So it's really good to have an angiographic and then kind of draw it as close possible to the bony landmark. Intradural portion, we talked about it. By default now, we all know that ophthalmic or C6 is the first intradural portion of the ICA, and then eventually communicating and terminus. These are all the intradural branches, okay, or the segments rather. Ophthalmic artery, this is another kind of science behind it. Like we can spend, there's tons of literature on the ophthalmic artery and what is it, why is it that important? Obviously, vision is very important, but again, there's tons of syndromes for the vision. You can have cranial neuropathy and so much in the play, right? You can have artery, you can have cranial nerve, you can have disc edema from the back pushing on all the stuff. This is part of the vision perception. You get information by just looking, but the understanding of the vision, and we have these agnosia syndrome and Balint and all this, all the action happening of digesting and understanding all this information that coming. Think about like a visual input. Before understanding I'm looking at a screen, I need an input, and then all the explanation is happening in the back, in the temporal and the occipital lobes. So it's very important to have this first before he goes there, okay? But again, first branch of the ICA, and then and connect to them. We talked about the dangerous anastomosis. One of them is the ethmoidal branch of the IMAX. Why is it important? Again, if you just shut this down or you have a moyamoya disease, these arteries going to stay alive because of this guy. Very tiny, very tenuous branch. Okay, I have been burned before, so I have to ask. So do you, I have about, quite a bit. So quite a bit. So tell me, and I'm sorry if I'm kind of too slow, but I want to kind of have a purpose with this talk. Want to make sure you guys understand everything here. So Mustafa and Dakatra online, tell me what you guys want to do. Do you want to pause here, ask questions, and we can regroup on another hour later? Dr. Abbas.
Sorry, Dr. Abbas Fadheel.
Assalamu alaikum.
Assalamu alaikum.
Thank you so much, Dr. Alhamza Al-Bayati, for the scientific lecture, roadmap from ARC to Cortex. It was a detailed review of neurointerventional anatomy, provide a clear and practical roadmap for navigating from aortic arc to intracranial vessels. I really appreciated the emphasis on anatomical variant like bovine arc and dangerous anastomosis, which is a critical subject to us, especially for doctors working on neurointervention. Understanding this pathway is very important. Neurologists should know this arterial neuroanatomy. Those doctors who have interest in stroke management. It was a scientific, comprehensive lecture containing in-depth information. I have no comments. Thank you. Thank you so much. The word is yours, Dr. Abbas.
Thank you, Dr. Abbas, for this nice comment. Now we move to Q&A section. Dr. Shafaq.
Thank you for this nice lecture. Anyone have a question?
So عندي أكو سؤال إجاني بالchat group. Did you guys شفتوا الchat group السؤال صح تشوفوا؟
Yes, yes.
Okay.
Can you elaborate about common sites of aneurysm and IVMs?
IVMs أي صح.
This map.
So صحيح. So هنا so a couple of things just to continue to share. You see this, right? You're still seeing it? So
yes.
Oh, perfect. So this is not like an ACA, but this is a great picture here to look at. So every time we say an aneurysm in the brain, there's many, as you know, there's aortic aneurysms and everywhere aneurysms, etc. In the brain itself, there's a saccular aneurysm where you see it kind of saccule, or you have this fusiform aneurysm where things are kind of enlarging, okay? So the saccular aneurysm typically happen because there's so much pressure on this spot. Remember, we talked about the layers of the blood vessel. Each blood vessel has like a intima, media, adventitia. So every time the blood vessel goes right and left, there's a pounding spot in that very weak spot in here, okay? This is one of them in the terminus, one of them in the anterior communicating artery. There's A1, A2. This spot is very common. There is branches in the PCOM, huge. The PCOM, so posterior communicating artery, this spot is extremely vulnerable for aneurysms. Ophthalmic as well. So you can literally, every time you see a branching point, there's an aneurysm possibility. The most common is the posterior communicating, anterior communicating, ophthalmic, and ICA terminus. These are the major, and the basilar artery. Same concept. It goes up and down or left and right. This is the spot. AVM is a more kind of a broad because people could be congenital, right? And it's an area that can literally happen anywhere in the brain. More common possibly in the posterior circulation and the frontal lobes, but generally speaking, it's a more congenital disease. Whatever you're born with, you can have an AVM. People have it in the lung, people have it in different in the eye. So literally it could be very generic problem.
There is another question. What about anatomical changes that occur with advancing age? Can you mention the most important ones?
Yes. So with age specifically, tortuosity. Okay. So there are two components to age. Either we start having problems because you just age, you live longer. So the odds of you drinking, smoking, having bad diet keep going, right? So you have a steno-occlusive disease. You have buildup plaque. Again, in the bifurcation, typically happen the most. This is ECAD, or extracranial atherosclerotic disease, or ICAD, intracranial atherosclerotic disease. Typically, the ICAD in the siphon around the cavernous segment, or MCA or ACA. And the most common spot for ECAD is in the bifurcation. Okay, so you have a steno-occlusive disease. You build up plaque over and over and over. This comes with age potentially as well. And then you shut down. Or you have the tortuosity. Again, we talked about early with the aortic arch. When things are like twisty because we live longer, elasticity of this blood vessel, you have like عندك صندة مع الحديقة وكل ما تعتق كل ما تشوفها like stretch أكثر وأكثر وممكن يصير bubbles on the side of it or tire ينشق or the same concept, right? As you grow older, the thinning of this blood vessel, the layers of them could be stretched and then increase elasticity and cause you to have problems. So that's that.
Thank you.
There is
another question from Meridian Abdel Karim. He said that he was a bit confused by a term intradural when described the internal carotid artery. Is this considered intra or extradural when it passes through the cavernous sinus? I think you refer to intracranial carotid artery as intradural after it emerged from the cavernous sinus.
Good, thank you. Very good question. So no, so the cavernous sinus is still extradural. Okay, all the branches, as you guys see it here, of the cavernous ICA is not cavernous sinus. Sinus is, think about it as like a accumulation of the venous flow, right? So all the stuff, the arteries, this is all arteries. And then there's a whole world of veins. And then you have the cortical veins, and then a bunch of different superior and inferior petrosal sinuses, the jugular vein, all this. But the connection between the small cortical veins and the jugular vein, the external, internal, is through these, what we call petrosal sinuses. Inferior and superior petrosal sinuses. You have two of them each side, and they all go and meet behind the eye, or the kind of the pharynx area is the cavernous sinus. What goes in the cavernous sinus? You have these cranial nerves that we named them, and then you have also the artery. So the artery is the ICA. The artery segment is called cavernous ICA. Still extradural, but it's intracranial. Why is it cranial? Because it's beyond the petrous ICA. Petrous bone is the landmark of extracranial and intracranial ICA. And then keep going as an intracranial, keep going here, and then you have the posterior genu in the back, pointing backwards of the cavernous ICA, and then you have the anterior genu of the ICA, okay? Both of these are the cavernous ICA, right? And then after that, you have we talked about the clinoid, the bone, and what's near that is the dural ring. Remember, I showed you this, the dural ring picture, very important. This is where things start becoming here. In this ring, we're becoming right here, this one. Yeah, dural ring, proximal and distal. Anything beyond that become intradural. So again, to summarize my answer, the first branch or the very first step of becoming intradural is the ophthalmic artery or the ophthalmic ICA, just after finishing the clinoidal segments. So if you ask me what are the ICA segments being intradural, number one is ophthalmic, number two is communicating, and then terminus. Anything clinoidal, cavernous, lacerum, petrous, and cervical, they're all extradural.
Thank you, Doctor. Dr. Murad asked a question, which is the most common segment in the internal carotid artery effect in the head trauma, leading to dissections?
Yes, dissections, very simple. I mean, there's so many things that we are not very definite about in medicine. Like you always kind of, oh, maybe this, maybe that, who knows? This is not who knows. We know what it is. Cervical ICA. Why is that? The same concept. Remember, we talked about the V3 being and part of eventually the talk goes down into the vertebral artery in more details. But the V3 is the most common spot for unprotected. Why is unprotected? Is outside the bony canal. Same thing here. You have a common carotid in the chest, very deep, okay? It's in the clavicle. Technically, sometimes we poke the neck to go to the brain because we don't have access. So this is the moment you put ultrasound gel here. You see, you guys put maybe in your residency central lines, you see the jugular vein, and you put the central line. Next to it, the pulsating is the carotid, which is the common carotid artery. And then shortly after becoming bifurcated, becoming ICA and ECA, that from here to the bone, you can tell how fragile that segment is. Very vulnerable, not protected, because here is protected, here is the skull base protected. So by default, the cervical one, the C1 or the cervical ICA is the most vulnerable for dissection.
Thank you. Any question?
Yeah, very great. Very important.
Yes, Dr. Mustafa Shani asked a question, how much is important for neurologists to know about vascular anatomy? Yes, if it's the last.
Yeah, very important. I mean, that's why you guys here and I'm here and all this. It's a whole by itself. And I know بالعراق maybe things شكرا لجهودكم that يعني تسوون exposure على هذا الموضوع كلش هواية. بس it's حرامات يعني احنا بالكلية like عنده جلطة ستروك وخلاص. That's it. It's like وبعدين شنو منو ليش so yeah, كلش مهم the more you understand it, the more maybe بعدين بالعيادة تشوف المريض تعطيه اسبرين وتقول له في لا احتمال كبير مع الأسف بس هذا الموجود. مو كل هواية مو كل واحد تنكسر رجله يروح للعملية، اوكي؟ or لا عنده more than جبس، ممكن just جبس وخلاص. so هذا يعني like هاي اكو مثل وهي مو شلون بالعربي اقول لك يعني مخانه لنا طب اطباء اعصابيه راح تعطي اسبرين وبلاد بريشر وخلاص. Like no, there are a lot, it's a huge science behind it. It should make sense. And then before even تسوي referral للنيوروسيرجن or head and neck surgeon, you need to understand all this information before even refer on the patient. But good ختام مسك. شكرا. خوش سؤال.
Thank you,
Mr.
Dr. Hamza Al-Bayati, for this nice
تفضل.
and unique lecture, really. And we wait for second part of the lecture, and another time we will date it for it. We remind you to follow us on social media and to join our network if you have not now. We are open to hear from you to develop our work, and we are looking forward to meet you at Babylon Stroke Summit coming soon. And also we're waiting for the second part of the lecture. Last and not least, we want to thank Abd Ibrahim Pharma for supporting this webinar. Have good night. Thank you, Dr. Hamza Al-Bayati.
صباحا على خير. مع السلامة.